Hello and welcome to the National Women's Law Center Making the Grade on Women's Health webinar. At this point, I'd like to introduce our speakers for today. First, we have Judy Waxman and Bridget Corto of the National Women's Law Center. We also have Michelle Berlin with us of Oregon Health and Science University. And now, with no further ado, I want to turn the floor over to Bridget. Bridget, if you're ready, it's all yours.
Thanks, Amelia. And first, I just want to say thanks to everyone for joining us today. We're really excited to share information from our 5th edition of the Women's Health Report Card with you. So first, I just want to give you a general overview of what we'll cover today. We'll give you some background on the report card, how it came about, and what it encompasses. And then because this is the 10th year anniversary of our Women's Health Report Card, we are going to spend a little bit of time looking back over the past decade, from 2000 when we published the first Women's Health Report Card to this year's information from 2010. Then we're going to share some more detailed findings about 2010. And finally, we're going to spend a moment talking about what we're looking forward to in the future for women's health, including a discussion about our new health care law, the Patient Protection and Affordable Care Act. So before we get started, it's always a little helpful for us to know our audience. So ask you to just take a minute and pick the answer that best describes the role that you play and the reason that you're here. So I'm going to pause for just a minute while we get the results. So it looks like we have a pretty decent mix with about a quarter national and state advocates here. And a fair amount, 20% of government and official staff, so that's great. Okay. All right, so to give you some background on the Women's Health Report Card, it is a comprehensive assessment of women's health at the state and at the national level. And we wanted our assessment to be as thorough as possible, so the Women's Health Report Card really reflects various factors that influence women's health. So we do two things. First, we grade and rank the nation and the states on 26 health status indicators. We actually have 34 total health status indicators, but for a handful of indicators, there isn't a target attached to that indicator. So for those indicators, we give the raw data, but we don't actually grade the state. And the goals that we use, the targets we use, are primarily set to fall in line with the Healthy People 2010 objectives. And when we started the report card, we actually were using Healthy People 2000 objectives. And of course, many of you may know that last week the Healthy People 2020 objectives were just released, so we have been reviewing those as well. But for the 2010 report card, we used the Healthy People 2010 objectives. And the second thing that we do, in addition to evaluating how healthy women are, we also look at a set of policies that states can enact to support women's health, and there are 68 total policy indicators. And now I'm going to pull up a website, our website, our Health Report Card website, so that I can give you a demonstration of what some of our policy and our status indicators are. It's going to take 1 second for that to load. Hopefully you can all see this. So I'm going to show you in live time on the screen some of our status indicators. So again, hrc.nwlc.org, you can pull this up yourself. And if we click on status indicators, and we have a bunch of different subtopics here. The first, women's access to health insurance services, and women without health insurance is one of our status indicators. Let's see. We have a subtopic on addressing wellness and prevention. And we have indicators on screening mandates, whether women get pap smears, whether they get mammograms. We also have whether women exercise, the rate of smoking, death rates. So I encourage you to go online and look at some of these indicators. Our policy indicators, on the other hand, similarly, we have subtopics here. So I'm going to go down to our preventive care subtopic, and we look at whether states have mandates, insurance mandates, that private insurers have to cover pap smears, for example. We look at whether there are requirements for high school students to take physical education courses, so whether states have a maternal mortality review board. That just gives you a good idea of what some of the policy and status indicators are. Okay, back to our presentation. Okay, so moving on, I mentioned that one of the most exciting parts of the 2010 Health Report Card is that it marks the 10th year anniversary of our project. It is the 5th edition of the report card, and that means that for the first time ever, we can compare a decade of data. So we've done an analysis of women's health over this past decade, from 2000, again, when we first published our report card, to 2010, to this year's data. This chart just shows you some examples of where we note some considerable progress or decline. So over the decade, we note in the progress area that fewer women are smoking, more are getting colorectal cancer screenings, fewer are dying from coronary heart disease. But on the other hand, we also see that fewer women are getting pap smears in 2010 than were in 2000. More women are obese. More women also have high blood pressure, and down at the bottom there you see more women are also participating in binge drinking. And, of course, we're also interested in what's behind the success of these indicators where there's been progress. So here are some common factors that we've identified, and I'm going to use the reduction in the percentage of women who smoke as an illustrative example here. One common factor are federal policies and resources. So with the smoking example, this ranges from federal regulations on the production and the marketing of tobacco products to a considerable amount of research on nicotine addiction and new smoking cessation drugs. We also note that in these areas there's been state policy change. So you can see in this chart here, we give 3 of our own policy goals for anti-smoking and how states fared in 2000 compared to 2010, and you can see in each case we went from low single-digit numbers of states that actually had and were meeting this policy goal. So, for example, does Medicaid program cover smoking cessation treatment? Only 6 states did that in 2000, but by this year, 31 states are doing it. Whether states have an adequate excise tax on cigarettes, only 3 states were meeting that goal in 2000, and that's increased tenfold. Okay, and now I'm going to hand it over to Michelle Berlin to share some key findings.
Thanks, Bridget. So we're going to go over a little bit of some of the information for you, and as Bridget has said, there's much fuller information available to you when we're done on the website. When we look at the report card, there's 2 major pieces of it. There's a national report card and a state-by-state. And if you look at the national report card for health status indicators, we really are not doing well. The national grade is unsatisfactory. And there were 3 benchmarks, only 3, that were met by the country as a whole. So that's the proportion of women receiving mammograms, the proportion of women getting colorectal cancer screenings, and annual dental visits. And a massive, I think, 23 benchmarks were missed. So that is concerning from our standpoint. So I have a question for you. We're going to do another quick poll here, and the question is, which health status benchmark was met by every single state and the District of Columbia? So why don't you click in here which of these 5 choices you think it is, and I'll give you the answer in a minute. And it's looking almost neck and neck for a couple of them. And so we'll say most people thought it was mammograms, which is incorrect. And the next group of people thought it was colorectal cancer screenings, which, as you're going to see in just a second, is correct. So when we look at each of the states individually, the two status indicators that were met by every single state were the annual dental visits and colorectal cancer screening. The mammogram was not. But again, look at all the status indicators that were missed by every single state. And there are a compendium of issues that underlie all this, but as you can see, all of these are important markers of health and of the opportunity to be able to improve health. So quite concerning in our view. The other thing I always find intriguing is looking at the range between various states. So the top-ranked states are Vermont, Massachusetts, and Hawaii, as you see, and those states have done pretty well over the 10-year period. And the bottom-ranked are the three southern states that you see, Mississippi, Louisiana, and Arkansas, and again, those three states have been pretty much towards the bottom throughout. When we look at the range, again, that's intriguing. In the coronary heart disease death rate, here you can see that the lowest rate is in Hawaii at just about 61%, and the worst is Washington, D.C., almost triple that. Obesity, you can see the range for Colorado to Mississippi, and then diabetes ranging from 5% to just about 13%. Now, as people sometimes want to be able to say, it's just if you move from one state to the other, your health status will improve, and of course that's not at all the case. This is really a reflection of a number of different factors, and we can talk about that in the Q&A. But it's a marker of something quite important in terms of the circumstances that people are living in. The next slide then shows you the overall state grades, and again, not a particularly stellar performance. No state got a satisfactory grade. Only 2 states got a satisfactory minus, Vermont and Massachusetts, you can see up to the right. Most states got an unsatisfactory grade of 37, and 12 states failed. So that is where we are for that piece, and I'm going to turn it over to Judy.
Hi all, happy to be here. Just getting over a cold. I hope it doesn't interfere. So I'm going to handle the policy issues, and to follow on where Michelle left off, we do look at over 60 policy indicators, and in terms of which states actually did the best, California met 44 of our policy indicators, New Jersey and Massachusetts following right behind, and Mississippi only met 10 policy indicators. And you can see here of 2 of the goals that every state met, and then on the other side we have no state actually had sufficient laws for abortion clinic access protection, and only 1 state actually bans gender rating. I hope all of you know what that is by now, charging women more for health insurance, and this is in group plans. A number of states do ban gender rating in individual plans, but only 1 for groups. So what I want to move forward to is really the new health law, the Patient Protection and Affordable Care Act, because it is quite significant that when we looked at all of the policy indicators that we use, we found that there is incredible promise of the Affordable Care Act to actually address so many of the policy issues that we're concerned about on a state level. And obviously our hope is that women will get healthier once all of these plans go into effect. So we have 3 columns, just so you can kind of see where we are. When you go back and look at the health policies, you'll see that there are a number on access to health insurance. So there you are, Medicaid issues, insurance regulations, other patient protections, and so forth. They are really all fully addressed by the law, and I will explain that as we go along. A number of issues are what we call partially addressed, and we have a sampling of them there. So, for example, contraceptive coverage isn't mentioned in the law, but we are very hopeful that it will become part of the preventive health care package and then be covered in every plan with no cost sharing. And so each of those that are listed here do go part of the way towards reaching the goal that we had for the health policy. And there is a pattern on the ones that are not addressed at all. Many of them have to do with reproductive health, particularly abortion issues, and some of them go beyond what we think of as traditional health insurance issues anyway, such things as minimum wage and gun control, which we all think affects women's health, but were not at all addressed in this law. So we have more work to do. So let me go through a few just to show you what I mean. Coverage expansions. So primary ways that I call it ACA, Affordable Care Act, expands coverage. As many of you know already, I'm sure, Medicaid and the new insurance exchanges with subsidies to help people buy the plans. And so our goal has always been, one of our goals has always been, does the state cover working parents with incomes at or above 200% of poverty? And I'm happy to say that every single state now, because of this law, will cover every single person in the state, not just the women, but up to 133% of poverty, and I assume also many of you know, purchasing in exchange people will have subsidies up to 400% of poverty. Another thing that Medicaid has done for years is limit access to the program by requiring asset tests, asking all sorts of information about, your car and everything about anything you might own, and that is virtually eliminated, although not completely. So we put that here in this category. Just to quickly go over Medicaid, this is what it currently looks like, and so pleased to show you the next slide on what it will look like in 2014 when the new Medicaid expansion goes into effect. Okay, so here is another bunch of issues. We've selected a few. The ACA will ban practices that make health insurance inaccessible. So one of our goals was, does the state guarantee that individual plans, that people will be able to get onto an individual plan, the so-called guaranteed issue, and indeed ACA takes care of that. And another goal we had was, and I alluded to this before, will gender be something insurance companies can take into account when they either decide whether you get in or what your rates are? And that's going to be going too, at least for groups up to 100 and hopefully beyond. Here's another category of that we always looked at in our health report card, many important services. So, does the state require private insurance companies to provide coverage for maternity care? And we had done a study, which I know many of you saw in the past, where we looked at individual plans and found that the vast majority do not cover maternity care at all, and now there will be an essential health benefits package with many various things covered as we list here. Still, the Secretary of HHS has to put, as I call it, meat on the bones to flesh out exactly what will be in each of these items, but there will be a robust package. Additionally, we looked at whether states require all sorts of screenings as we list them here, and states do it in a variety of ways. The new law will does require that preventive health services, which include all of these things, will be eventually in all plans without co-payments or deductibles for the individuals. Access to reproductive health service. One of our goals is private insurers cover abortion services without restrictions. And again, I assume many of you have been down this road with us on the so-called Nelson Amendment. In the bill, we would say this only goes a little of the way. Certainly, abortion is allowed to be covered in plans in exchange, although plans need to go through considerable hoops to make that happen. Family planning services, also we've worked with many of you on this issue. States can expand, create a program for only family planning, but they have to go through the extensive waiver process. The new law says that states can do a much simpler version of asking the administration for permission by just asking for a state plan amendment. Additionally, worth noting here is that the new law does require family planning services to be in any Medicaid plan that any state is going to dream up in the future for anybody. Family planning will be required. Okay, other improvements in the Act, to go through this quickly. There are so many other interesting items which I call goodies, such things as helping the spouses of nursing home residents under Medicaid, another issue we had looked at, and also making sure that there's adequate funding for tobacco prevention activity that fits within a number of the items we have reviewed over the years. So, I'm sorry, you know what, oh no, it comes later. I'm going to send this back to Michelle for this part in looking at Healthy People 2020 and beyond.
Thanks, Judy. So Healthy People, as you heard, is we end up using a fair amount of information from it. When we started years ago looking for benchmarks and targets, we looked at a bunch of different things. Unfortunately for us, Healthy People provided a good framework. Healthy People 2020 has just now been released, and we will be looking at that with an eye to future report cards. And there's some very important things that have been thought through carefully with this new iteration of the Healthy People. So one of the most important things is it's truly been a revamp from top to bottom. There's a new framework that emphasizes what we now know is extraordinarily important issues in social determinants of health. There's a life course view as well. So, and there are some new topic areas and objectives that I think acknowledge newer issues that have newly been recognized in any case. So LGBT health, adolescent health, and issues for older adults. And then there are new targets set for 2020, which is the way this goes. Every time there's a new Healthy People released, there are new targets set. So again, we will be looking to these more as we proceed with the next sets of report cards. There are also some very important initiatives that have been begun throughout the federal government and other groups that I think are important to point out. One of them is the Department of Health and Human Services Coordinating Committee on Women's Health has come out with a multi-phase initiative called the Summit for Action, and that is a very important guiding document that's being used within the Department of Health and Human Services. The NIH Office on Research and Women's Health came out with a new strategic plan of late. HRSA, Maternal and Child Health Bureau, is doing some interesting work looking at different measures, outcome measures in women's health. And a key report was recently released by the Institute of Medicine talking about women's health research progress, pitfalls, and promises. And part of the reason why these are so important is that, as you will have been hearing from us, we're concerned about the progress that has not been made on the status indicator side. And I think, we all think, that these particular initiatives will help move that. And it's certainly heartening to feel that there's much more attention being made now to issues in women's health than there was even 10 years ago. So, I'm going to turn this back to Bridget and Judy to talk about this part.
All right, thanks, Michelle. I want to add on to what Michelle said. We hope that this report card has been part of the noise, cry, whatever, to increase the attention onto women's health that we're now starting to see. So we feel like we have been part of making that more of a priority for the nation. And so I want to sum up this report for all of you. Basically, over the past 10 years, we've seen some improvement and some decline. Bottom line is we still do have a long way to go, unfortunately, in making sure women are healthy in this country. One of the things we did learn, though, is that progress can be achieved with federal and state policies, changes, and public attention and awareness. Bridget talked about the smoking example, and there are others, so we can figure out how to take care of some of the problems we currently have. And lastly, I want to say the Affordable Care Act and some of the other studies and reports that Michelle has mentioned do provide enormous potential for both expanding coverage and improving women's health, and we look forward to the future when we can say, yes, indeed, we are moving more quickly towards our goals, and America has healthy women. I have one more question for you, and that is, after the webinar, do you feel that your knowledge of the state of women's health in the United States has improved greatly, somewhat, a little, or not really very much at all? Okay, well, as these numbers come in, I am really happy to say that we're coming out red and blue here, and that mostly everybody feels that at least their knowledge has improved somewhat, and a significant number even greatly. So we're very pleased to have made that difference for you.
And this is one thing to know is, as you're now seeing, there's additional information available online. You can certainly contact any of us through the information that you will see for further clarification, or if there's more information you would like to have.
And check out the website, and you can see the whole report. You can see how your state is faring and how you compare to other states, and how the new law is going to make a difference on many of the indicators we discussed. So thanks very much. We are happy to take questions, and Bridget is going to, she's fielding the questions now, and she's going to ask them, and we'll see who is the best person to answer.
Sure, and Amelia, do you want to give a reminder of how people can put in a question to the queue?
Absolutely, sure. So if you'd like to ask a question, just go to the upper left-hand corner of your screen, and you'll see that there's an option that says Q&A. Go ahead and click on that, and then a box will open. Go ahead, type your question, and just hit the Ask button, and then that will submit your question to our presenters. So thanks so much.
Thanks, Amelia. Okay, so we're getting a number of questions in, and I'm going to ask an early one, which is if you had to decide on one major women's health issue looking ahead to the future, what would that issue be?
Michelle?
It's the biggest concern, I think, is what this question's getting at.
I'm sorry, what's the question getting at?
What's your biggest concern in women's health going forward?
Okay. You know, we have a number of them, but I think if we were to choose one, it probably would be obesity. And while that's not particularly a new thing to hear, it is exceedingly important. And we're seeing how that's playing out in diabetes rates. We certainly are concerned about the physical education parameter that you've heard about. When that was set up in the policy side, at that point there was still a fair amount of physical education going on in younger grades. Now it's probably even more of concern. There are a lot of factors that play into that, but probably obesity is one of the largest ones. And in fact, that's even been pointed out at the National Cancer Institute. So it's really an across-the-board problem.
Right. Thanks, Michelle. Okay, we have another question here. Occasionally have a name, so this is coming from Laura Sneebold, who says, you may have addressed this at the beginning of the presentation, but how did you define satisfactory? That's a great question. Satisfactory is defined as whether or not a state met the benchmark for that particular indicator. And so at the beginning of the presentation, I did mention how most of our benchmarks are set using Healthy People 2010 objectives for national health. Occasionally we adapt an objective to be more appropriate for women's health, and in a few instances, we use a different source, but for the most part, they're Healthy People 2010 objectives. And if the state did or the nation reached that target for 2010, then it received a satisfactory. And then we have a formula we use to determine the other grades. The next highest range receives satisfactory minus, and then unsatisfactory, and the lowest range of scores receive a failing grade. And generally, because we are getting a couple of methodology questions here, I want to refer you to the report card website. If you scroll down to the bottom, one of the pages you have an option of linking to is our methodology page. And that would describe our data collection methods, how we did the grading. So if anyone has any additional questions about our methodology, I would refer you there. And as well as each indicator, each policy and status indicator page actually shows you the data source for that indicator. Okay. One second. Okay, here's another one from Lori Robinson. What do you think the chances are that the prevention funding will stay in the Health Care Reform Act and be implemented?
Well, I'll try to answer that, and I would say I really have no idea. There are two different major prevention provisions. One is the one I referred to, which does already, I should say, require health plans to cover preventive services with no cost sharing. And so that's already in effect for new plans, and that includes a long list of services, many of which we had on our list before, mammograms, chlamydia screening, pap smears, and so on and so forth. The other part that I think Laura's referring to is a large sum of money that is to go out to states to do prevention on a public health kind of a way to get out some of these messages, education, resources that, again, we feel are crucially important and would be very important, let's say, to combat obesity, just for one example. And but Congress is kind of looking at it as it's sort of a little more loosely defined, and so given the fights we are going to have in this next Congress on keeping the money that is already there in the bill, it appears like that pot may actually be somewhat of a target. It's kind of easier to go after than, let's say, the subsidy money, although I assume people are going to go after the subsidy money for individual coverage too. So I really wouldn't want to make a prediction except to say it's something we all need to watch and fight to keep.
Okay, great. Thanks for the question. And another question coming from Sabrina Matoff-Stepp is, because progress has been disappointing, what do you think can be done differently to learn from the programs and policies that have not produced results that we're hoping for in women's health status? And are there new ways to approach issues that have not been tried?
Well, I wish I had a really succinct answer for that. I mean, I'm sure there must be new things to try. Again, there are pots of money in the new law that are going out to states for a variety of things we support, like working with teens on unplanned pregnancy. There are going to be studies on how to do better quality of care. I mean, there's just so much in there that does, I think, I keep using the same words, but holds promise. And again, the lesson from this report card is that if we do make the policy changes like we have in smoking, and we do the outreach and education, that does work. So we need to do more of that, is what I would say. Join forces, make sure we are targeting policies that we think could actually help on a problem, and hopefully keep some of that prevention money so that we can do nationwide campaigns on why it is just healthier to eat less and exercise more.
And then Michelle here, I think there's an additional piece to it too. Of course, I agree with you, Judy. I think an additional part too is to really look at partners that may not be ones that have generally been thought of. So I think a multi-approach kind of set of answers is really what we need. We need to have innovation. We need to look to people who are in other spheres. You know, the built environment issues we know make a difference in obesity. I think we need to be refashioning how we're looking at all of these issues, and that, honestly, the new Cast to Healthy People 2020 encourages that, and I think will help too. So I think for those people who work primarily in public health programs, I think we all have to be looking to other new partners as well.
Great, thanks, Michelle. We have a question from Brooke Kelly, who asks, how did you come up with your indicators for women's health? What are they based on?
Well, it's a great question. I'm going to answer a little and let Michelle answer a little. We were both here at the beginning. Obviously, at the beginning of this, it was really Michelle, who was at the University of Pennsylvania at the time, and the NWLC staff. I was not on the staff, but I was actually on the advisory committee that came up with it. And we had a large two-day meeting, which we had all kinds of experts come together to talk about just what those things are that would, you know, a cross-section of which would determine women's health. We did look very much at the Healthy People 2000, it was at the time, to see what HHS is already looking at and modify some of those. And the policies really followed along with the status indicators. If we knew what we needed to do to improve women's health, if we knew what we wanted to improve, then we looked at what policy states have to just do just that. Michelle, I'm sure you want to add to that.
Thanks, Judy. Judy's right. There was a process that happened before Judy and the advisory committee were brought in too, which was to say what things really do matter from a health standpoint. And so there was a lot of vetting and a lot of work done to come up with a whole list of what kinds of parameters mattered. And if you look at the report card information itself and the methodology, you'll see that there were criteria that were quite strictly followed about what kinds of things mattered. So did a particular health issue involve a large proportion of the population? Was there a measure that existed or one that could be devised? So really this was a very careful process that wasn't let's see what the data is and go from there. It was a much broader look at what things do we think matter, then look to see what data we could find, then look for benchmarks, and then go from there. It's entirely true that the advisory committee was extraordinarily important in helping us to choose between them because, as you can imagine, we had a very long list after a while, things that met the parameters all the way around. And the policy part is absolutely integral because without looking at the policy piece, it's hard to say what kinds of programs and what kinds of policies are being looked at to try to address these issues. So we're very proud that this has a very important two-piece process, one of them the data, and then looking at how are those issues being addressed at the state level. And we will look to do something quite similar for the next decade's worth of report cards.
All right, thanks, Michelle. We have a question from Nicole Grafilo, which is, what are your thoughts moving forward on the lack of reproductive health issues addressed in the ACA?
Yeah, well, it's a problem. Again, we are hoping that maternity will be a meaningful benefit. We are watching that and watching how the essential benefit package is developed to assure that maternity, for example, is fully addressed. We are working towards getting every form of FDA-approved contraceptives to be considered a preventive service. I testified about that a couple weeks ago. That's what we're doing certainly with our partners in the reproductive health community. And, you know, abortion, if I could divide it into those three categories, abortion is the hardest one. That's not a surprise for anybody on the phone. Congress has changed or will be changing shortly, and we are taking a major step backwards, both mostly in the House, but even in the Senate, on having pro-choice members and senators. And we just have to keep on keeping on. We will be working very hard with our partners to defend what we have, and we are also in the process of figuring out how we engage in proactive measures, even within this atmosphere, to at least set the scene for long-term movement towards improvements in access and funding for abortions for women who need it.
Right. Thanks, Judy. We have a question from Vicki White about the progress being made in the area of HIV/AIDS for women. And I just wanted to, again, refer you to our website. We have a few policy indicators that are getting at this issue, as well as a status indicator on the AIDS rate among women. So if we look at the national AIDS rate among women in 2007, so this is rate, it's per 100,000 women in the national population, the AIDS rate was 9.4 in 2007. And then for the 2010 report card, it's 7.5. So we have seen some progress there in that 3-year period. And currently the nation's grade for AIDS rate is a satisfactory minus. And of course, you can go online and find out any state that you're interested in what grade and what their rate currently is. We also have a couple of policy indicators that look at different policies and programs that might help reduce the AIDS rate. One is, hold on one second, our policy goal of a state requiring that states have public schools teach STI and HIV education. And so in 2010, 36 states, so a large majority actually meet that policy goal of having a requirement in public schools for that sort of education. And another related policy, not a prevention policy, but on a healthcare service side, we also have a policy goal of the state requiring coverage for pharmaceuticals for individuals with incomes at or above 400% of the federal poverty level under what is called the AIDS Drug Assistance Program, or ADAP. And so in 2010, 20 states actually met this policy goal of having this pharmaceutical program for folks whose incomes might be too high to qualify for comprehensive Medicaid benefit or public insurance benefit. And actually that's 3 more states than when we last published our report card in 2007. Okay, I have another ACA question. The ACA, this is coming from Joanne, the ACA stops gender rating but not age-based rating. This will still negatively impact women who live longer on lower wages. And how will this affect women's health, and what possibilities can be done to mitigate this problem?
Well, great question. The age rating, so currently insurance companies are allowed to, except for some states that have regulation, which we've been watching, insurance companies use almost any measures they want to decide rates. So are there more women? Are there more older people? Are there people that work in hairdresser shops where they use a lot of chemicals? Are there construction workers? Or I was told by our own broker, well, you're a lawyer, so we up your premium 17%. I'm not kidding. I didn't make that up. So they could do just about anything. And in the future, now we're talking about for groups that will be in the exchange or out of the exchange at 100 employees or less, which is really where all of this goes on, mostly. It does go on a little beyond that, but it's mostly individual and the small groups. It would be restricted now that only things insurers can use are, one, how many people are in the family. Can't really complain about that. Two, where they live, because health insurance premiums or expenses are like higher in New York than Alabama, say. That will be able to be taken into account. As the caller said, age, but only 3 to 1. So older people can only be charged 3 times more than younger people, where now we've seen places where 17 times is charged more for the older people than the younger, and also whether or not you smoke. Smokers can be charged 1.5 times what non-smokers are charged. So it's much more limited, but you are right, it's not totally equal. And this does not apply, though, to people over 65. So the living longer, I don't know how much that plays in, really, because over 65, we're all in Medicare, and it is all equal there. None of these factors are taken into account for premium on Medicare. But, of course, women do make less money. There's no question about that. And the older we get, really, men and women will be charged a little bit more for group or individual insurance. And really the way to fix that is to improve the law over time. I do believe that this law has many, many things that are fabulous. I would not say it is the end-all and be-all. I call it a big major step forward, like Medicare and Medicaid were a major step forward. CHIP was a step forward. This is a big step forward, but there's still a long way to go to make it all work the way we want it to. And once we get this in place, we're going to start looking at what improvements we want in the law. So I hope that answers the question.
Thanks, Judy. We have another question from Lisa, which is, what do the data show regarding the health status for women of color? Were there any data challenges related to understanding these differences?
Michelle?
Lisa, as you know, this is a recurrent issue, and it is part of the function of the report card to show where these differences are and where the problems remain. And so we present within the report card data by race, ethnicity when we have it. There are other organizations that have looked at this also. There's no question there are significant issues with being able to analyze the data correctly and being careful that we're collecting it as we wish. One major problem at the federal level is that even though there has been a requirement in place for a few years, the data be collected in the same way, it is not collected in the same way across different types of surveys and different studies, so it's very, very difficult to compare. So for better or for worse, I think there's much more attention being paid to this now, and that's certainly true over the last 10 years, but there's still a long way to go on that part as well.
Great. Thanks, Michelle. Okay, this question's coming from Suzanne. Please expand on the family planning waiver options. I think this is in reference to some of our slides on the Affordable Care Act. So do we know anything about the process for developing these new amendments and how that will work?
Yes, we do. So before this law passed, if a state wanted to expand its Medicaid program and cover just family planning for women up to a certain income level, usually states go up to their pregnancy level, which is higher than their full Medicaid program income level, so somewhere generally around 185 or 200% of poverty, they had to go through a whole complicated process called a waiver of federal law and show that they were going to save money. And it sometimes took as long as 3 years to get this waiver through. 26 states do have the waiver. Now, what the law did is say, okay, you don't have to do that anymore. You just have to, when you are telling the agency every year what options you take in the law, this could be just another option, and you'll just have to check a box. So since then, you can go on the website, the CMS, Centers for Medicare and Medicaid Services does have information that goes to the states and tells them how to do it, what the requirements are, and there is actually, I don't know what they call it, but it's like a form that states are supposed to fill out. And in fact, one state has gotten a state plan amendment approved, that's Georgia, and other states are considering whether they should switch over to a state plan amendment when their waiver is up, because it'll just be much easier, but there are sometimes internal factors to think about, but that process is ongoing. And if anybody needs names of people at HHS to call about it, give us a buzz and we'll get you just who to talk to.
Okay, great. Thanks, Judy. And I just want to remind folks we only have a few more minutes to take questions, so there's probably only going to be one or two more. So if you do have a question that you'd like to add to the queue, now would be the time to do it. We have a question from Carrie, and I think this is directed to Michelle. Michelle, do you see obesity as the highest state policy priority as well?
Well, far be it from me to dictate to states what they should do, but I think that it is an enormous priority in every single endeavor and in every single component. So I would say, were I a health planner, I would be looking at it at the state level, county level, school system-wide level. I think it's an important one. It has so many implications in so many other aspects of health that I think it warrants particular attention.
Great, thanks. And another question about being intrigued by this combination of state and federal policies and public awareness and attention that you talked about. Are there any other examples beyond smoking that you can elaborate on?
Yeah, we also point to colorectal cancer screening. So what you saw in our results was that now every state requires colorectal cancer screening. I'm sorry, that was wrong. That every state meets the benchmark, and the nation meets the benchmark. On mammograms, the nation met it, but every state individually did not meet the benchmark. That's why there was the differential there. So there has been improvement we can point to, and we do see that the number of states that have required it have gone up. There has been a lot of public attention. I don't know how many of you watched Katie Couric get her screening, but I know that was popular there for a while. But also there has been, I think because of that, other discussions, other resources, other education going on in the community. Maybe not as much as smoking, but enough for us to say that is another good example where we can see that some things do work.
Great, thanks. I think we have time for one additional question. This comes from Pam, who has a question. How is domestic violence screening and education on prevention of DV addressed in Healthy People 2020? And I would say to you, Pam, that I haven't had a lot of time to look in depth at the different topics of Healthy People. It was just released last week, and maybe Michelle would want to add to this if she has, but I encourage you to go to the healthypeople.gov website. I have been playing around a bit on it, and it's very accessible. It's easy to get to the topic that you're interested in, and to read a list of objectives for 2020. I also just wanted to note that we do have a policy indicator on whether states require domestic violence protocols for training for and screening by healthcare providers, and actually in the Affordable Care Act, there are a few places in the Act where violence prevention programs are listed among activities that, for example, the new Prevention and Public Health Fund could be used to support, and also in the ACA there's new grants available to states to provide technical assistance and training for identifying and making referrals for pregnant victims of violence. So I did want to note that. And I think we are basically at the hour, Judy.
Okay, well, thank you all for attending today. Obviously, it is a great deal of information. We are happy to continue to be in touch with you and answer your questions. As Michelle noted, we have a variety of experts on this project, and each of us will take the questions appropriate to us, but check out the health report card, tell your friends, and give us a call. Thank you very much.